Thank you, everyone. I really appreciate this opportunity to tell you a bit about our Reducing Asthma Disparities program. We call it RAD. It's an asthma home visiting program that we started in 2008. And so there's three things that I really hope that you get out of today's presentation. The first one is that asthma home visiting programs, like the one I'm about to describe, can make a difference in childhood asthma. The second is that this program is based in sound science and good asthma management. And finally, I hope to persuade and encourage you to follow in this endeavor and that you too could have an asthma home visiting program in your community. I would like to acknowledge that this project was funded by the CDC, and again, we started in 2008. The Department of Health and Mental Hygiene was our IRB. We had two principal investigators, and we had 5 co-investigators, each of who brought a set of skills and experience that made this program successful. So let's talk a little bit about asthma prevalence in Baltimore. All right. So as you can see on the slide here, 20% of children in Baltimore have asthma. This is current prevalence. This is much higher than the Maryland and the national rate. Okay, let's take a look at ED visits then. So when we compare it to Maryland ED visits, we see that Baltimore City children are going to the ED 2.5 times more frequently than statewide. You look at asthma hospitalizations, you see something very similar, is that Baltimore City kids are being hospitalized for asthma more frequently than our state counterparts. Okay. Now these two indicators are really important to look at, ED rates and hospitalizations due to asthma, because it's a sign that a child's asthma is not well controlled. Okay. So as you can see on this slide, Baltimore City is not unique to the rest of the state. But what's alarming is the disparity between blacks and whites when it comes to urgent care visits. So if you look closely at the far right, you'll see Baltimore City, and you'll see the number of African Americans, the rate, and how much higher that is compared to whites. Okay. We know there's something going on. So what other disparities exist in Baltimore that can have an impact on asthma? Children living in poverty. This is an astounding number. 37.3% of Baltimore children actually live in poverty. That is much higher than the Maryland rate and higher than the US rate. Adult smoking rates. We just heard from Dr. Diet that smoking can have an impact on asthma. And so what's going on in Baltimore? This survey showed that adults in Baltimore, 28% of them smoke. But what's even more alarming is when you look at household income. When you see that a family earns less than $15,000 a year, that goes up to 36%. And that will become significant when you look at our RAD study results. Housing statistics. All right, let's talk about mice. Dr. Diet did. We know that it's important. It is an asthma trigger. So nationally, it doesn't look like it's that much of a problem. We got 6.3%. Let's take a look at Baltimore. We're looking at 34% on average. Median age of housing stock. In Baltimore, we realize that we live in an older city, and the average age of a home is from 1947. So you wonder why this is important. The reason why this is important is because in older homes, it's more likely to have leaks, drips, entry points for pests, and make it hard to maintain. When you compare this to the national age, it's around 1974. Okay. So to address asthma disparities in Baltimore, what did we decide to do? We went for funding, we received funding through the CDC Translational Research Grant, and we decided to translate the work of Seattle-King County's asthma home visiting program. It's an evidence-based program. Like Seattle, we focused on reducing home environmental triggers and asthma medical case management. Now, when we started, we thought that we would spend most of our time on the home environment and working with triggers and families. But what we found that was equally important was the amount of time we spent with families to go over medication, understanding the difference between a controller and a rescue med, having medications that are up to date, understanding when to take them, how to take them, asthma action plans, and follow-up appointments. Our target population, children with moderate to severe asthma. Okay, how did we determine this? So this was determined by a questionnaire that was completed by study staff prior to enrollment. Those questions included symptomology in the last 2 weeks, so looking at daytime, nighttime, rescue medication use. We also asked about ED visits and hospitalizations in the last year. And we chose children between the ages of 4 and 18 who are Baltimore City Public School students. So one of the most important aspects to making this program a success were the partnerships that we developed while we set up RAD and while we were running RAD. So in the health department, we know that we're good at certain things, right? So we're good at community organizing. We're involved in the community. We know the resources that are available. We're tapped into internal and external groups that can help families in need. But where we needed strengthening was in our partnerships and our clinical expertise. So we reached out to our asthma clinicians here at Hopkins. We had allergists, pulmonologists, and general pediatricians who were working in the trenches with families of children with asthma. And that made a huge impact on the direction that we went. Asthma champions also able to share information with us in the community about their own experiences so that we could learn from that, but that they could also advertise and promote our program. Area hospitals and universities. Okay, where this came into play was that with the backing of Hopkins and University of Maryland, what we were able to do was it gave us the credibility and the ability to do research, which otherwise might have been more challenging. And we also wanted to coordinate with area resources. So the Greater Baltimore Asthma Alliance, otherwise known as GABA, that's an asthma advocacy group locally here. And they spend their time with asthma education and disseminating information. So what we did is that throughout the study period, we would go back to GABA and we would ask for feedback. We'd share with them our findings, some of our challenges, some of our successes, and ask for feedback. Because not only was this a study, but it really was a program, an implementation of science, and that we really wanted to have a good service for children in Baltimore. And finally, local area researchers. So we knew other people in Baltimore were doing asthma home visiting studies. So we wanted to make sure that we weren't soliciting participants from other studies, and we wanted to share information. So what were the goals? We wanted to decrease asthma morbidity, asthma symptom days, use of urgent health services, and exposure to asthma triggers. We also wanted to increase provider knowledge of the home environment and communication with families. So what did we do? So this was a 6 home visit intervention over 6 months with a 1-year follow-up. And in between the 6 months and the 1 year, we had follow-up phone calls that the community health worker did. So many topics were covered in each of those home visits, but highlights is what I've included here. Medication and technique, identification of asthma triggers, trigger reduction education, and coordination with providers. So what did we use for our data collection? All right. So what we did is we collected data at the beginning of the study and then at the very end 1 year later. We used 2 instruments. The first one was a baseline interview. It was an extensive form, and it was about the medical management of a child with asthma. So it included symptomology, ER visits, hospitalization, episodes, asthma action plans, caregiver quality of life, medications, medication technique, allergy testing, you name it, it was in there. Very comprehensive form. And then the second instrument we used was the home environmental assessment. So this was key to the program because the community health worker at this point would do a walkthrough with the family. And what they would do is they would walk through the living room, the kitchen, the bedroom, the bathroom, and the basement if there was one. Okay? They do it with the families, looking for asthma triggers, opening up cabinets, looking for holes between pipes, where pests can move in and out, looking for evidence of mice and roaches, which are extensive in Baltimore City housing in this study that we found. And also to educate families. And what happened is that based on this baseline and this home environmental assessment, that really geared the direction of the education that the family received. So the final piece was the encounter form. So this was a 2 or 3 page document that went to the medical provider or providers of the child, of the child that we were seeing. And what that did is that it was kind of this little snapshot of what a community health worker did in the home, which was really nice because we looked at symptomology, daytime, nighttime, rescue medication use. We looked at medication technique and what meds were in the home. We looked at ER visits, hospitalizations. We also recorded what we had discussed, our protocols, our problems that we identified in the home. And those problems include everything from med adherence, med technique, mice, roaches, smoking, etc. Okay. So we also did goals. So the community health worker sat down with the family and said, okay, hey, we got this, all these things that we can work on. What do you want to do first? Okay. Set tiny goals so that when they come back, they have some success. And if they didn't meet those goals, then talk about why and try and come up with new goals. It also included date and time for the next visit. So the beauty in this tiny form is that it went to the medical provider, and often we got feedback from the medical provider that included things like, I had no idea there was a mouse infestation. I need to add this to the regimen. Or, I haven't seen this child in 2 years. Very helpful. We would go back then to that family and say, okay, is there another provider that your child is seeing? If not, let's make a follow-up appointment. Okay. So what did our baseline data look like? So we're looking at 102 kids. The majority are African American, mostly boys. Average age around 9. Family size about 4. About 2 people in the household had asthma. And significantly, looking at this, almost 97% of the kids were Medicaid. So we didn't select for Medicaid kids or low income, but it's just kind of what happened. So this mirrors a little bit of what Greg was reporting in his studies, that on this initial assessment, this is what we found, that almost 59% of families had mice, 42% had roaches, 38% had a furry pet, and that 31% of the primary caregivers smoked. Okay. So after the intervention, pre-post data is what we're looking at now. So what were the reported changes in the child's health? Okay. This is over a 2-week period. So we saw a decrease in symptoms, decrease in nights awakened, a decrease with having to stop their play, a decrease in rescue medication use, and happily, an increase in controller meds. Okay, what else did we see? Well, so at that initial visit, we asked about hospitalizations. How many times had that child been hospitalized? So out of our study participants, they'd said that a child had been hospitalized 44 times. Okay? At 1 year, it was 32. 12, not a big difference, right? Until you look at the cost of an average hospitalization in Baltimore City. So the average cost is around $7,900, and depending on the institution that they go to, it can be higher or lower. So that number will become important in the next slide. The other is the number of ED visits. So pre-intervention, 240 ED visits is what families had reported. So then when you looked at it 1 year later, it's still a high number, 139, but it's 101 fewer. So if an average ED visit in Baltimore is $772, that begins to add up. Okay? And the mean number of ED visits in the past year actually did decrease. That was significant. Okay. Cost averted. So we look at the hospitalization and ED visits, and that total cost is around $172,000. So we're looking at almost $1,700 per child is what they're costing the system. Home visiting program costs, about $141,000. And you're wondering, okay, what does that include? It includes the community health workers, nursing supervision, a referral coordinator that I'm going to talk about soon, and supplies. And those supplies included mattress and pillow encasements, pest management supplies like baits, gels, copper mesh to plug holes. It also included a mop, a bucket, and green cleaning supplies like baking soda, Bonami, vinegar, so non-toxic, and a vacuum cleaner. Okay, so the average cost for a child in the program was about $1,400. So the difference is around $304. That's the potential cost savings. All right. So how does this compare to our counterparts who we were translating the research from, Seattle-King County? All right, their program costs are similar, about the same, $1,300. Now, their direct medical cost averted is a little less, $124 to $147, compared to RAD. But there's some subtleties here in this slide that I'd like to point out. The first is that Seattle-King County, their data is coming from 2001-2002 cost data, versus ours, we're looking at Medicaid cost data from 2011. Okay. The other is that the RAD data is self-report. Okay. And in Seattle-King County, they had medical records. And so what we're doing now is that we're actually examining our Medicaid kids, and we're looking at Medicaid claims data, and we're doing a pre-post intervention analysis to determine if our self-report data does actually mirror the actual cost data. Lessons learned, infrastructure. So if you're going to undertake this, know your institution's strengths and identify where you need assistance. So like I said earlier, the health department, great with partners, great with community, and they know the resources, right? And also we have a very holistic approach to working with families. So we have a community health worker model. So for example, if Brandy, one of our community health workers, goes in to see a family and mom is stressed out and she's all worried about her gas and electric being cut off. So the first thing that she's going to do is not to be talking about asthma and how many days the child has had symptoms and did they sleep well last night. She's going to pull out her resource book and said, have you called blah, blah, blah? Have you called this resource? Okay, is your phone working? All right, let's use mine. Actually connect that family to those resources right then and there. And then that provides that gateway, that entry point, and also that confidence in this person who's now entered their home to say, hey, they're here to help me. Okay. Program database. So we didn't have one when we started. It took about 6 months to get something up that was just a skeleton. It took a year for us to get something that really we could pull information out of, that we could look for loss to follow-up, overdue visits, etc., run reports on the community health workers and their caseloads. So just knowing what your strengths are and knowing where you need to build in more time is important. Staffing. I'm a firm believer in the community health worker model. I feel like they have this unique connection with families in Baltimore that they're able to communicate important information in a way that families understand. And the beauty of this is that we have a nurse manager who is the support for the community health worker. And so that encounter form that I was talking about, that the community health worker fills out, that actually goes to the nurse manager, every encounter form. She reviews it, sends back feedback to the community health worker and says, what about this? Fix this, da-da-da-da-da. The community health worker fixes it and then sends it off to the physicians. Referral coordinator. So what's the referral coordinator? So basically, we currently get between 40 and 60 referrals on a weekly basis, especially in the high season for asthma in the spring and the fall. So we found out early on that we needed referrals to be funneled through one person. So this referral coordinator, she gets every referral that comes into the program. She enters it into the database. She screens every call. So that means that she completes the questionnaire to determine eligibility. And then she assigns the case to a community health worker, makes the chart, puts it on the calendar of the community health worker, sends out a letter to the family, etc. Extremely important part of the program for us. And the other is to recognize the training that's involved when you are working with staff. So you make sure you have to build in the time for it. And that what we did here is that we looked at our asthma partners, and we had the community health workers actually go into the clinic setting where they could observe clinicians working with families with children with asthma, so they could kind of see and learn a little bit more about what happened in that kind of exchange. And it also gave us the opportunity for the clinicians to get to know us a little bit. Okay, so that is Brandy, or that is Tyra, who, I've just spent the day with, and she's going to be sending me, encounter forms on this kid. So it's always nice to put a name with a face. The asthma training was extensive, and it's something that's always ongoing. So it's not just that one-time thing. It's the weekly meetings that the nurse manager has with her staff. It's the monthly updates that are a little bit more in depth, that make sure that the community health worker is confident in their knowledge and how they're presenting this to families. Healthy homes. So we know that the environment where we live, where we work, where we play, has a huge impact on our health. So what we did is we used the National Center for Healthy Housing, and the community health workers and staff actually took the Healthy Homes Practitioner course. It was a multi-day course, and then they did refreshers. And one of the nice things is that in-house we actually had an IPM expert. So for those who don't know, IPM stands for Integrative Pest Management. So it's a green way of managing pests. Very important part when you're looking at a healthy home. So we did a lot of internal training also to refresh and so that the community health workers were comfortable when they were actually looking in the home and looking for asthma triggers. And finally, we used motivational interviewing. So we had an expert come in, do multiple trainings with the community health workers and the staff, because the community health worker already has this really nice relationship with the family. But sometimes you need just a little bit more knowledge to identify where a family is in the stages of change. And so when you're able to do that, and you know where a family is, and you know kind of how to target your teaching, and that's what the motivational interviewing did. Other lessons learned: referrals. Initially, we thought we were only going to be getting them from school health. We had planned on that, because we were thinking that those would be the children that were not in a medical home. What we found was that when our IRB finally came through, it was in late spring, and so school was almost out. We had a ton of referrals from school health, but we knew that summer was coming and we needed to branch out. So we went to our clinicians, we went to area hospitals and EDs. And as a result of that and the partnerships that developed, we were integrated into 2 systems. And so in those 2 systems, we now get weekly updates from one of them, and the other, it's built into their electronic medical record, so that when a physician is seeing a child for asthma, not only are they checking, did I give the child an inhaled corticosteroid? Have I sent them for allergy testing? What was their ACT test score? And they can also check for home visiting. Okay? So what that does is that makes it easy on the clinician and makes it easy on us, because we get the referrals and then we can act on them quickly. What we also found was that the ratio of number of referrals to actually kids enrolled was about a 1-to-5 ratio. It varied a little bit depending on where the referral was coming from, but about a 1-to-5. And I talked to some other area researchers here in Baltimore, and they said that they'd found the same. So it was about right. And then the partnerships and coordination of care. So that clinician buy-in, extremely important. So what we did is we did in some of the clinics in the area, we did like brown bag lunches or early morning breakfasts, and we tagged on to their monthly meeting, and basically kind of said, this is what we're doing, this is our program, this is how we hope to be helpful to you, this is how you do a referral. Okay? Asthma Champions became a huge kind of advocate for us, and that included school health nurses and actually local and state government. and then database management. So what we did was that we got our database up and running, but then for our baseline and 1-year data, we moved that with the program evaluator to the University of Maryland, where she could actually analyzing it using statistical modeling and all that fancy, statistics to show our results, which was very helpful. So conclusions. So going back to the beginning, I was hoping that you would see that asthma home visiting programs can make a difference in childhood asthma. So in this study/program, we saw that we decreased triggers and symptoms, decreased ED visits and hospitalizations, and increased med adherence. There was a cost savings about $304 per child. And that the most important part is that this actually confirms the other research that's already out there, that asthma home visiting programs work, and they should be incorporated into comprehensive asthma management. Greg's slides showed it. Seattle showed it. I was recently in Chicago, and they also had the same CDC grant. They have very similar results. So it's time now to move the research into practice and to have these kinds of programs integrated. And that's it. Thank you.